Good morning, everyone. Thank you for joining us for the virtual symposium on essential tremor. My name is Marnie, and I'll be helping Dr. Kamani and Dr. Gwynn in the background. There are a few things that I'd like to share. First is our disclaimer. The video is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding your medical condition. Please note that this event is being recorded. We ask that you submit your questions through the Q&A feature in the upper right-hand corner. All attendees are muted and will remain muted during the duration of this event. I will be monitoring and publishing all questions. If you don't see your question published, it is likely because a similar question was asked. I will do my best to make sure that we don't have repeat questions. You may submit your question at any time, but we will be holding all questions until the end of the presentations. Also, this is our first live event with Microsoft Teams, so if we experience technical difficulties, please bear with us. Dr. Kamani will begin with a 30-minute presentation, and Dr. Gwynn will follow with a 30-minute presentation. The last 30 minutes of the symposium will be held for questions and answers. If you have any questions following the symposium or would like additional information, we will post our shared email box on the last slide. First of all, I'd like to quickly introduce our speakers. Dr. Pravin Kamani is a practicing movement disorder neurologist practicing at Swedish Movement Disorder Clinic in Seattle. He attended medical university at Wayne State University in Detroit, Michigan, and completed his residency at the University of Texas Southwestern in Dallas, Texas. He completed a fellowship in neuromuscular disorders at the University of Texas Southwestern and a fellowship in movement disorders at Stanford University in Palo Alto, California. His clinical interests include Parkinson's disease, tremors, deep brain stimulation, ataxia, Huntington's disease, and dystonia. Dr. Ryder Gwynn is a practicing neurosurgeon at Swedish Medical Center, where he's practiced since 2004. He attended medical school at the University of California, Los Angeles, completed his residency at Washington Hospital Center in Washington, D.C., and his fellowship at Yale University in New Haven, Connecticut. His professional interests include epilepsy, movement disorders, pain, tremor, functional neurosurgery, neuromodulation, neuroendoscopy, and spine. Thank you, and I hope you all enjoy this event.
Is that my cue to get started, Marnie?
Yes, it is.
Okay, before I project my slides, I just wanted to turn your attention to the chat box here. There are questions coming through, and then there is an echo, which I don't understand, Marnie. Should I just ignore that?
Yes. Maybe turn down your mic a little bit, or turn down your speakers.
On my speakers. I hope that's okay, because I still hear an echo. I just want to make sure if someone from the audience can give you a thumbs up that they can hear us, that would be great. Now the echo is gone, which is fantastic. So I'm going to start projecting my first slide, and if people in the audience are not able to hear me or see my slides, please alert Marnie. If I don't get a cue from either Marnie or the audience, then I'll just keep going through the slides. Is that all right, Marnie?
That sounds great. Okay,
so let's see if this slide comes through. All right, good. So before I go through the slides, I would like to thank Marnie Davis, who was critical in putting the symposium together, the Swedish Science Foundation, B, for all the technical support, my esteemed colleague, Dr. Ryder Gwynn, who is our neurosurgeon here at the Swedish Neuroscience Institute, for taking time out of his busy schedule to talk about surgical treatments for essential tremor, and most importantly, all of you guys for taking time out today on a Friday morning to sit down with us and discuss essential tremor. I know we couldn't meet face to face, but I hope this gets the points across. And I think we had one of these symposiums last year. This is our second symposium. We hope to do more in the future on essential tremor and tremor going forward, because they're very treatable neurological diseases. Over the next 25 to 30 minutes, the learning objectives of my talk are to know a little bit about what is a tremor, and more specifically, what is essential tremor, what are the drugs that treat essential tremor, what is a non-invasive treatment for essential tremor, which is non-surgical, non-drug related. This is unique since our last symposium, so I'm excited to present this information. And then finally, I'll talk briefly about the neuromodulation process or candidate selection for surgical treatment of essential tremor before I hand it over to Dr. Gwynn to talk about the actual surgical processes.
Dr. Kamani, your slides are not presenting right now.
Okay, good to know. Thank you. And let's see. I'm going to, when did they stop presenting?
I don't think they've gone live.
Okay, so I'll start right from the beginning, and you could hear me speak though. Am I coming across? Can you hear me though?
Yes, they hear you, but they cannot see your slides. They see you.
They see me, but not the slides. And what about now? Let me know if this helps.
I'm going to send them live. They should see them momentarily.
Okay, I'll wait until you give me the cue.
Can someone comment if you can see the slides? Yes, they can see slides now.
Should I go ahead and advance them from my end?
Yes, would you try that, please?
Okay, sorry about that, folks. A couple starting troubles here. You heard me talk a little bit. Now, in terms of the slides, I'll just repeat what we're going to learn today. We're going to learn about essential tremor and tremor. We'll be focused more on ET. We'll talk about drugs that treat essential tremor. We'll talk about a non-invasive treatment for essential tremor, and we'll talk about the neuromodulation or selection process for essential tremor. I'm going to stop here for a second to make sure you guys can see my slides. Any feedback, Marnie?
Yes, they can see slides. Thank you, everyone.
Okay, I'll go ahead then. All right, so before we talk about what is essential tremor, let's dwell a little bit on what a tremor is. A tremor is a rhythmic oscillation of any part of the body, primarily the limbs, but it can involve the head, the voice, the torso, the soft palate, etc. The two important characteristics of a tremor that allow us to measure tremor are frequency and amplitude. We'll see a slide in which we'll talk about the numbers of oscillations of tremors per second, which defines its frequency, and the amount of distance a limb travels when it is having a tremor, which is amplitude. Tremors are state dependent. The two most common states in which we see a tremor are action and rest. And we will be focusing on action or essential tremor today. Maybe in the future we can do a talk on rest tremor, Parkinson's tremor, and other tremors that are out there. So what generates a tremor? The hypothesis currently is that there are tremor generators in the brain. I'm going to use my laser pointer here to see if I can. I hope that is visible. They're central tremor generators or brain circuits that are activated when you move your arms, particularly in essential tremor. There's a misinterpretation of these signals in space. The brain circuits that are part of the tremor generators are firing off incorrectly. Messages are sent through electrical signals down nerves which connect to muscles, and those messages, if you will, are transduced into a tremor. And the two properties we talked about were amplitude, which is the distance a limb travels when it is tremoring, and this can vary from second to second, minute to minute, and hour to hour, but there is a certain range for specific tremors, and usually the frequency stays within the range. The amplitude, however, can change. So the frequency over here is the numbers of oscillations or the movements per second. Those are the kinematics of tremor, but we really don't diagnose tremors this way. We don't usually use electrical devices in the clinic, although that would be a good way of objectively assessing tremor. We use our clinical skills in the movement disorders clinic to identify and distinguish between tremor and other movement disorders. And this slide illustrates some of the various movement disorders we see in the clinic that might mimic a tremor. The most common neurological and movement disorder in the world are essential tremor, ET, and RT, which is rest tremor, seen in the context of Parkinson's disease. But we have other movement disorders, hyperkinetic movements or excessive movements such as dystonia, chorea, myoclonus, tic, dyskinesia, and then functional tremors that can resemble essential tremor or Parkinson's tremor. So it is the job of the movement disorder specialist to determine whether the hyperkinetic disorder is a tremor, and number two, whether it is an essential tremor or some other kind of movement. According to a recent classification on tremors put together by these clinicians that you see on this paper and scientists, tremors were divided into several syndromes, and the division is based on the clinical manifestation of the tremor. So in order for us to identify a tremor syndrome, it is important to sit down with the patient to do a thorough examination, get a narrative of the tremor, and do investigations if needed to determine what kind of tremor syndrome it is. And that put together with the clinical data allows us to determine the cause of tremor. And I'm going to stop over here for a second and ask Marnie if there are any problems with the slides or visualization of the slides, Marnie?
I believe we're all good. We've had several comments that they can see your slides. Okay, great.
I'll keep moving on. All right, and this very busy slide shows you those tremor syndromes I talked about. ET and ET plus, the most common tremor syndrome, followed by Parkinsonian tremors, which is that rest tremor seen in the setting of Parkinson's disease, are what is most commonly we see in the clinic. But in addition, we have focal tremors that can affect only the voice, the head, the jaw, and sometimes task-specific tremors. I've had musicians come in and say, well, they're not able to play the guitar because they have a tremor in their hand, and it's the only movement disorder they have. There are other tremors called dystonic tremors, which can mimic both essential tremor and rest tremor. And then we have functional tremors, which are due to a completely separate cause. There are different brain circuits are involved in the development of functional tremors, so therefore the treatment for functional tremors is different from the rest of the tremor syndrome. Enhanced physiological tremor is a really mild state of enhanced tremulousness. It's not really a disease and doesn't need to be treated. It's usually due to anxiety and drugs, etc. Today, however, because of our limited time, we will focus primarily on essential tremor and essential tremor plus syndromes. So both ET and ET plus are one of these several tremor syndromes. ET is purely an action tremor that can affect the hands. The cause is usually unknown. We call this idiopathic. We have some risk factors for essential tremor we'll see in just a bit, but we don't have one definitive cause for everybody. The tremor can affect head, voice, and leg. but it must affect the hands. That is one of the critical requirements of this new criteria. Ideally, in order to make a safe and 100% secure diagnosis, the tremor should be followed for at least 3 years to make sure you're not developing any other neurological problems or neurological syndromes that could argue against the diagnosis of essential tremor. However, if you have mild balance problems, mild memory problems, deafness is very common in people with essential tremor, and mild dystonia, which is a twisting or a turning of the hands or feet, which are non-progressive. They are considered to be part and parcel of essential tremor, and it's called an essential tremor plus syndrome. In fact, in our clinic and in the world, essential tremor plus syndrome with these mild neurological abnormalities that are non-progressive is significantly more common than just pure essential tremor. And this is true as we age, we accumulate some neurological deficits that don't necessarily need to be treated separately from essential tremor. It always comes up, well, what is, how many people in the world are living with essential tremor? How many people in the USA are living with essential tremor? These epidemiological studies are difficult to do because they have to be done over long periods of time involving large groups of people. But Dr. Lewis, who is a foremost authority in the treatment and research in essential tremor with his colleague Dr. Atman, determined that perhaps 7 million people, which is a very large number on average, have essential tremor at any given time in the US. This is also based on data extrapolation from other studies. Obviously, they didn't study 7 million people, so this is more of an extrapolation and a statistical number. The prevalence of essential tremor does increase with age. So that brings us to, the risk factors for essential tremor besides aging. Genetics always comes up because at least 50% of people with essential tremor are able to provide some family history. They know someone in the family who has a tremor like theirs. And just because you don't know someone in the family doesn't mean that they didn't have a tremor either. So we suspect that there is a significant genetic underpinning, if you will, of essential tremor. We just don't know what those specific genes are that trigger it and cause it to progress. How about medications? There are medications that we see on a day-to-day basis in our clinic that can worsen essential tremor, but don't necessarily cause it, and I have a list that I'll show in a second. How about Parkinson's disease per se and other neurodegenerative diseases? They don't necessarily cause essential tremor, but they go hand in hand with essential tremor, particularly Parkinson's disease and essential tremor. Environmental toxins such as harmaline, these are toxins released by in slaughterhouses or when you burn meat, etc., are known to be potent exacerbators of essential tremor. They are thought to cause essential tremor, but then again, not all of us are around slaughterhouses or burning meat, etc. So there, those of us who have essential tremor, even without exposure to these toxins. So that's maybe not the complete explanation, and it's a combination of various factors: aging, genetics, neurodegenerative disorders, and maybe environmental toxins together that cause and maybe trigger essential tremor. In terms of aging, I've got these two studies that I put up, one done in India in a wide spectrum of people with over a large age range, and the other done in the USA in people over 70 years of age. The trend basically shows that essential tremor increases significantly with age, as this graph shows. The prevalence per 100 increases as people continue to age, both in the Indian and the US study in the USA. And although the study is 10 years old, I think the data is still valid because this is what we see in our clinic as well. Moving on to the genetics of essential tremor, I briefly talked about the 50% number approximately of folks with essential tremor may have a known history. There have been 10 to 12 genes now loosely associated with essential tremor, but really there's no role for genetic diagnosis yet. We don't have a specific gene unless there is a very strong family history and multiple members in the family are affected with essential tremor. Then we may do genetic tests, but that is usually not the case. And more importantly, we need to understand what to do with that data or that genetic mutation. I think it is great for research purposes, but not currently for clinical treatment. More studies are needed and more studies are being done, and this would be really important because there might be a subset of people with a particular genetic mutation for whom a specific treatment can be designed, knowing what the mutation does and knowing the downstream effects of those mutations, not unlike we are doing in other diseases such as spinocerebellar ataxia when we know the mutation. Medications in essential tremor, we see this very commonly in the clinic. These medications can significantly exacerbate a tremor. If you are on any of these medications and you recognize them, please do not stop them suddenly. You have to consult with your referring physician, and some of these medications are lifesavers. Amiodarone is a double-edged sword. It's called Passerone. It's an antiarrhythmic. It's a very potent antiarrhythmic for AFib and atrial fibrillation and other diseases, but it also causes significant tremor. And you don't obviously stop it unless you consult your cardiologist. And then there are others such as inhalers for asthma. That can temporarily make tremor worse. Valproate, metoclopramide is a common offender that can cause both essential tremor and also cause symptoms of Parkinsonism. And this is a huge no-no in our clinic. We don't want people to be taking this drug. Thyroid medications can cause essential tremor, particularly if you're taking an excess of thyroid medications. Hyperthyroidism can cause tremors, or at least exacerbate tremors. And then there are immunosuppressants like tacrolimus that can potently exacerbate tremors. Antipsychotics, commonly seen, these are used for the treatment of bipolar disease, schizophrenia, etc. They can make all kinds of tremors worse. Lithium can actually cause a tremor itself, and it's very commonly recognized. However, again, these medications are probably very necessary for those people who are taking them to keep their psychiatric disorders under control. Talk briefly about essential tremor and Parkinson's disease. So what is the connection? Well, there is, at least in our clinic, we see a significant overlap between symptoms of Parkinson's disease and essential tremor. Whether the person actually has Parkinson's disease or not is what the movement disorder doctor is charged with finding, investigating, and confirming, because the treatment of Parkinson's disease is obviously different than the treatment of essential tremor. If you've had essential tremor for a very long time, 10, 15, 20 years, and you develop Parkinsonism or Parkinson's disease, it's understandable, but typically you don't develop essential tremor after having Parkinson's disease for a long period of time, and we don't know why. And I think that's just the physiology of the brain. We haven't unraveled that mystery. Here it says there's a variable prevalence of Parkinson's disease essential tremor of 3% to 20%. That's a very wide range. In our clinic, anecdotally, I see a quarter of the patients with essential tremor having some form of Parkinsonism or having concomitant Parkinson's disease. So what we need is a thorough exam by the movement disorder specialist. And in addition to the examination, we have certain other tips and tricks. One is a trial of levodopa. Levodopa is a medication that is used to treat Parkinson's disease. And if the medication improves a portion of the tremor, so for instance, the tremor at rest, and it has a sustained response, and then it's a fairly high possibility that the person has Parkinson's disease in addition to essential tremor. And then we have another test called the DAT scan, which I use routinely in the clinic. DAT stands for dopamine transporter, and I'll show you a picture that can aid in the diagnosis of essential tremor versus Parkinson's disease. What about clinically? And I hope this video plays. This is a video of a woman who's laying down and whose right arm is shaking at rest, and that's one of the ways to bring out rest tremor. And you see her tremor over here on the right hand side. It's a classic rest tremor. She does not have postural tremor or action tremor. These are some of the maneuvers we do in the clinic as part of the Unified Parkinson's Disease Rating Scale. And she's trying to demonstrate that she does not have a tremor when she's holding a cup and bringing it to her mouth and back. When she's tapping her fingers, you see that the amplitude and the speed is not very good. It's low. She's not able to open her fingers up fully. That is called bradykinesia or slowness. Pay attention to her walk. Her steps are slightly smaller. Her posture is slightly stooped. She turns a little slowly, and you see a tremor in her right hand, which is a rest tremor coming out. So she has demonstrated slowness, a rest tremor, maybe short strides, slow turns. What she has is Parkinson's disease, not essential tremor. And this is just a clinical examination. I haven't done any investigation yet. How about contrasting it with this gentleman who is laying down just like she had and counting 1 to 10 or 10 backwards, which is a maneuver to bring out tremors. And we see no tremors in his hands or his feet, in contrast to the person we saw earlier. And here's trying to demonstrate the cup to mouth test, and you see a clear action tremor as he's bringing the cup to his mouth and then back out and trying to give it to me, both on the right side and the left side. The left side may be a little more affected than the right. An essential tremor is always asymmetric, with one side being more affected than the other. His finger taps are big, and they're bold. They don't slow down. The speed is fairly good. He does not have bradykinesia, and that's important to recognize. And he demonstrates that through more than one maneuver. This portion of the exam is called drawing the Archimedes spiral. This is part of our tremor rating scale, and a spiral is quite abnormal, particularly on the right-hand side. This is another confirmatory sign for action tremor. Together, this gentleman's picture is that of essential tremor, not Parkinson's disease. And to complicate things, here is a lady with a tremor at rest. You can see her right hand and right leg shaking, but she also has a tremor when she lifts her hand up, her right hand up. That is called a postural tremor. So she has a tremor at rest. She has a tremor when she lifts her hand up. She also has a head tremor, and a head tremor is not very common in Parkinson's disease. And she's had tremors for decades. But off late, she's become slower. She's become slightly stooped. She's also developed a tremor in her right hand at rest, which wasn't there. So she has a mixed rest and action tremor and signs of Parkinsonism. And when it was investigated further, she was found to have both essential tremor and Parkinson's disease. Here's that DAT scan that I talked about, dopamine transporter scan. My laser pointer is pointing to a scan which is normal. In essential tremor, this scan should be normal. In Parkinson's disease, this scan is abnormal. This is one quick way of determining whether someone has essential tremor or Parkinson's disease, or both. If you have both, the scan would be abnormal. And typically I send people to get the scan here at our institute at Swedish and also the University of Washington, which has a quantification method for the scan. Now that we talked about essential tremor and how we diagnose it, what about the treatment? This seminar is about treatment. Well, before we talk about treatment, I'd quickly like to show you this slide over here that shows you the tremor rating scale that we use to identify the severity of tremor. We have an objective score. We talk to people about the disability that the tremor is causing, and then we also have another objective motor score. A severe tremor is considered to be a grade 2 or greater, depending upon the presentation and the amplitude of the tremor. It's about greater than 2 to 3 centimeters. It's considered to be moderate to severe tremor, and that is important to recognize because the same scale can be used for diagnosing tremors as well as to determine the effect of the intervention or the treatment. So we do it before we start a medication, and then we do it after we start a medication or perform an intervention. The scores are usually graded from 0 to 4, 0 being no tremor, 4 being the most severe tremor that you can get based on this rating scale. So for a mild tremor, which is not interfering with day-to-day life, we talk to the patient, dialogue with the patient, and we can follow the patient over time to make sure that the tremor stays mild. But once the tremor starts getting into the moderate to severe category and interfering with day-to-day life. And we expand the discussion to pharmacological treatment, non-invasive treatment, and surgical treatment if none of the other modalities are working. Pharmacological treatment is most commonly used for essential tremor in 2020, and the two most common drugs are highlighted by these two red arrows: propranolol, which is a beta blocker, and primidone. It can be given in doses of 10 milligrams to 320, sometimes more. Primidone, 150 to 450 milligrams are needed for being effective in tremor, but at those very high doses, it can cause side effects, and we'll see what those are in a little bit. There are other drugs, gabapentin and topiramate, for those folks who cannot take propranolol or primidone for various reasons, but they don't have as robust an evidence for treatment of essential tremor as propranolol, primidone. Atenolol, sotalol, these are two beta blockers that can be used as well, but then again, not as robust as propranolol. And then alprazolam or Xanax, I rarely use it because it is habit forming, and it is really, it has side effects that are quite intolerable. So talking about drug efficacy and compliance, the problem with these medications are approximately 50% of patients have 50% improvement over a certain amount of time. But as the tremor worsens, you have to use more and more of the medication. And the problem is the compliance goes down. Why? Because you're taking more medications. The pill burden increases. We all know we don't like to take a whole lot of pills. I can barely remember to take a vitamin a day, and I'm telling my patients and their caregivers to take medications 3 to 4 times a day. That could be problematic. And the medications are less effective as tremor progresses unless you increase the dose of the medications. But then when you do that, you can have side effects. The side effects of the medication, basically, I'm going to talk about two that are most commonly used: primidone and propranolol. The most important thing in terms of reducing side effects with these medications is to start really slowly and increase gradually. I always check liver and blood function tests because the primidone is a sort of a barbiturate that can have cause liver and blood abnormalities, albeit rare. But if someone has a predisposition to liver disease or has blood function abnormalities, I always do labs before I start the medication. If you start at a very low dose and increase it gradually, you can effectively increase the dose in a majority of the people. But if you start at 50 milligrams right away and ramp it up, majority of the people are not going to be able to tolerate the medication. Dizziness, lightheadedness, vertigo, drowsiness, confusion, double vision, fatigue, and lethargy are some of the things that people complain of in higher doses, and particularly if the medication is ramped up real fast. And then primidone can also interact with other medications such as blood thinners. So one must be cognizant of those interactions as well. Good medication in selected people, but one must know what the side effects are and what the interactions are. Propranolol is a beta blocker. Beta blockers are those that reduce heart rate. They're used in heart failure. They're used in myocardial infarction or heart attacks, etc. Very commonly used medications. They work for tremor. Again, you've got to start it slowly and very gradually increase it. If someone already has arrhythmias, cardiovascular disease, I always talk to the cardiologist and get clearance from them to ensure that it's okay to start the medication. Some people cannot tolerate it if they have a low resting heart rate. If you're an athlete, for instance, or if you have a low resting blood pressure, this medication can reduce the heart rate further, reduce the blood pressure further, and cause dizziness, lightheadedness, occasionally depression. Fatigue and lethargy are likely due to the low heart rate, and those could be reasons for which people are not able to take the drug or increase the dose. And you have to also watch for interactions with other medications. There are certain diseases in which you don't want to give this medication, such as asthma, because it can exacerbate the disease. Now we jump into non-drug treatment, this particular therapy, Calatria from CalaHealth, was not available last year when we gave the Essential Tremor Symposium. It was just FDA approved then. And since then, I have prescribed it to several people with varying degrees of success. You don't need to fail drug therapy to try Calatrio. This could be your first line treatment, and you can use this even when you're on medications for added benefit before you consider more invasive options. What it is a stimulator which has an accelerometer in it. The stimulator stimulates the median and the radial nerves in the wrist. Those messages go to the brain circuits and disrupt them, desynchronize them, and as a result of that, you have a transient improvement in tremor for about 90 minutes to 2 hours in some people, and greater than that in others. Your wrist is stimulated for 40 minutes. Then you remove the stimulator and put it in the charging station to charge it. This particular charging station is unique because it captures the kinematic data and shares it with the scientists at Calatrio that can determine the amplitude and the frequency of the tremor after stimulation, and even share it with the prescribing physician. And that way we know what the objective parameters are, and if they're being treated or not. This particular band is replaceable, and this has the stimulators in it. It is not insurance approved yet, but there's a certain out-of-pocket cost, and there's a try it before you buy it period of 2 months. And more information is available on their website in Calatrio. What about the benefits of Calatrio? Well, here's a video that shows a pre and a post. Before treatment on the top panel, and after stimulation at the bottom panel, there is a marked improvement in the tremor severity and the amplitude, which translates to functional improvement. And in the next video, I believe we see a functional task, which is pouring. This is pre-stimulation. And post-stimulation, the lady is able to pour water, much more smoother fashion. So there is a significant improvement post-stimulation. And if you need more information about Calatrio, please visit their website, and they have 1-800 numbers that you can talk to. You still need a prescription to get the device. Right. What about if none of these options work? Is there treatment for medically refractory essential tremor? The answer is a resounding yes, and that's when we delve into surgical treatment for tremor. You gotta stay tuned for Dr. Gwyn's talk. I think I'm cutting into his talk a little bit, and I'll be stopping here momentarily. His talk's going to follow mine, and he is going to tell you all about the surgical treatment of essential tremor. I'm going to briefly talk about candidate selection and what our neuromodulation process is for deep brain stimulation and focused ultrasound. What is deep brain stimulation? What is focused ultrasound? That is what Dr. Gwyn is going to talk about briefly. So who is a good candidate for deep brain stimulation or focused ultrasound in essential tremor? Someone who has an accurate diagnosis of essential tremor, because the treatment is dependent on having essential tremor. Medications should ideally be fully optimized or maximized. If you've never taken medications and you come to the movement disorder clinic and say, well, I want surgery right away, that's not going to happen. The benefits of surgery need to significantly be greater than the risk, and that can only happen if we've tried medications and you've failed them. The tremor has to be disabling. It can't just be an annoying tremor. You're able to do everything but not able to thread a needle, and those are not candidates for surgery. It has to interfere with writing, with drinking, with eating, with several tasks which are on the tremor rating scale, and it has to be at least a grade 2 based on the movement disorder doctor's assessment. You have to complete the neuromodulation process. And what is that? I'll show that in my next and last slide, I think. You got to have realistic expectations. If you want absolute fine motor control tremor, control of your tremor, 100% improvement for 100% of the time, that's likely not going to be possible with a surgery. The tasks that improve are the gross motor tasks I talked about. The Swedish neuromodulation process, and we won't go through this, basically is a selection process for for a surgical treatment of tremor. You meet with the movement disorders doctor, you get a few tests done, we meet and review the data, you get a consultation with the neurosurgeon, and then we determine if you're a candidate for deep brain stimulation or for focused ultrasound. You get the procedure done, you visit with the movement disorders doctor, and then you have regular follow-up. If you have deep brain stimulation, the way I think Dr. Gwynn will tell you, as one side is operated on, and then after 3 months you get surgery for the second side for essential tremor. So in summary, I'm sorry I ran a couple minutes over. Essential tremor is very treatable. I think we saw that. We have several modalities to treat it. The treatment must be customized to the patient's needs in terms of medications, in terms of clinical observations, in terms of surgical treatment, obviously, patient's needs and tremor severity. And the three modalities we talked about were medications, Trio, and surgical treatment, which Dr. Gwynn will talk about in just a minute. And then I talked about the neuromodulation process, which is a prerequisite for surgical essential tremor treatment. Okay, so I think that concludes my presentation. Sorry to rush to the end, but we will be sticking around for questions, and thank you very much. I'm going to hand it over to Dr. Gwynn right away. I'm going to stop sharing my slides. Let me see if I can do that.
Great.
So take it away, Dr. Gwynn.
Excellent. Thank you very much. Can everybody hear me? You guys can hear me? Excellent. So again, I'd like to thank both Marnie and Bea and Dr. Kamani for helping to put this whole event together. As Marnie has said, it's our first webinar event, and it's very exciting and cool, but we would actually love to see you guys all in person if we possibly could. Is my face projecting now also out there? I'm seeing Dr. Kamani.
I will you're live now.
I am live now. Okay, great. Great. So I'm going to go ahead and share my slides. And I'd really like to thank you guys for paying attention today and being technologically savvy enough to get everything going so that you can see our presentations. Are my slides up now? Can people see my slides? Great. I'm going to now try to minimize this window. Okay. Can people see only my slides now?
Yes.
I'll take that. Oh, good.
Yes.
Okay.
Here's people are commenting yes.
Perfect. Perfect. All right. So let me go over things. This is kind of the agenda for my portion of the talk today. I'm going to review a little bit of the tremor network that Dr. Kamani already talked about, but really I'm then going to go into the three different types of interventions that we have that are beyond medication and beyond this Trio device that he talked about. First is deep brain stimulation, then I'll talk about Gamma Knife, and then end up with focused ultrasound and give a little patient experience along the way. So first off, there is a network that is involved in the development of tremor, and Dr. Kamani talked a bit about it, but it really is the same network that we use for what's called proprioception, and this is what lets us know where our arms and legs and head are in space, and it consists of little receptors in the muscles and in the joints and in the tendons that tell your brain how much things are stretched or compressed in those muscles. Those signals then go through the spinal cord up into part of the brain called the cerebellum, and then up through another part of the brain called the thalamus, and then onto the cortex where it's processed and motor kind of signals are sent back down to the spinal cord and to the muscles again. But I really want you to focus on this little area right here in the thalamus called the VIM nucleus, because that's the center of action for all of our therapies. The thalamus is a major relay station in the brain, so a lot of information goes back and forth between the thalamus and the brain surface, both on a sensory level and a motor level and a lot of other levels as well. As I said, this thalamus has a small part within it called the VIM, or Ventralis Intermedius. If you look here on this MRI scan, this is the thalamus in here, and then I'm going to kind of blow that up. This is a representation of the thalamus here, and our target, the VIM nucleus, is a very small part of the thalamus right here. And so all of our therapies are directed towards this little area in the brain. It's smaller than the size of a grape. And so everything we do has to be very precise so that we're affecting this area, but no other areas, because critical structures are very close to this VIM nucleus. And we do indeed think that this nucleus is involved in the generation of the tremor, because we know that the cells that are firing there have an abnormal pattern that is in the same frequency as the tremor that we see in patients. I want to just kind of emphasize that it is very much a team approach to treat patients who have tremor. Our team includes Dr. Kamani, who is a movement disorder neurologist. We sometimes employ neuropsychologists to make sure that there are no cognitive issues that will interfere with you benefiting from these therapies. We have clinical specialists who are typically a nurse practitioner or physician's assistant who really helps out a lot with the education for our patients, and then is often in the operating room and doing some of the testing with me, and then doing some of the programming as well afterwards. Then there's the neurosurgeon, who's myself, and we have another movement disorder neurosurgeon, Dr. Gerard, and actually a third, Dr. Nora, as well. And then also you'll see a lot of people in the hospital during these therapies, the nurses and support staff. So it really does take a village, a great team to put all of this together, and I don't want to minimize that fact. So first, let me start with talking about deep brain stimulation then. This is really kind of the gold standard, has been around for the longest period of time, and has the most evidence that points to its effectiveness. There are pretty strict criteria about who can be considered a good candidate, and Dr. Kamani kind of went over that, so I won't go through the details, but you have to have a significant functional problem. It has to be interfering a lot with your quality of life. It has to be a significant amount of tremor, and you have to have very good expectations about what this intervention is going to do for you. So that's what a lot of this team approach is about, is making sure that we're selecting the right candidates. This here, you can see that deep brain stimulation was first approved to treat essential tremor. It was the first thing that we could help with deep brain stimulation, and that was approved by the FDA in 1997. So we've had more than 20 years of experience in treating people with DBS. Since then, we've also had FDA approval to treat people with Parkinson's disease, people that have dystonia, other disorders such as obsessive compulsive disorder, and epilepsy as well. Epilepsy is the most recent FDA-approved indication for deep brain stimulation in 2018. So what is DBS? It's basically a three-part system that's implanted in the body. The first is a brain electrode, and that's inserted to the very target that I was talking about, this VIM nucleus. And then that is then attached to an extension wire that is tunneled underneath the skin down to an area just below the clavicle in the chest. And then that's where a pulse generator is surgically implanted. And this is the battery and the device that runs the stimulation. And basically, the whole system provides continuous stimulation to the tip of this electrode, which essentially functionally shuts down that part of the brain without actually destroying it. So as soon as you turn the therapy off, the brain goes back to what it was doing before. So it's a very reversible therapy once it's implanted. There have been, as I said, this therapy has been around for over 20 years, and there's been a lot of recent advances that I think make this therapy even more exciting than it was in the past. One of them is what's called directional steering, and you can see on the left here, this is the old electrode that was originally devised and approved in '97, has been really in use for the last 20 years and even is in use today. And you can see you can stimulate one of these electrodes to shut down or affect this nucleus, which is kind of the area that we're after to treat. However, if the electrode is off by even just a couple of millimeters, then if we stimulate this area in a kind of a spherical fashion, we might have some of the signal go into other areas of the brain that we don't want it to. So we actually have electrodes today that are what's called segmented, and so we can send that electrical stimulation to one side or the other, and that allows us to correct for a very minor displacement of the electrode that could be due to movement of the electrode as it's going through the brain, or technical problems with imaging or targeting. So that's really helped us to kind of perfect the surgical therapy for DBS. Another big advancement that has been put out is something called fractional stimulation. And that means that in the past, we've had to turn one of these contacts either on 100% or off, so there's zero current going through it. But now we have an ability to give an amplifier to each of these contacts, and so we can turn each of these contacts on in 1 degree elements. And so we can turn each one on 20%, 40%, 80%, and this allows us to kind of move the stimulation up and down the electrode in a very smooth fashion and a very continuous fashion. So we're not kind of jumping with our electricity from one contact to the other. And so we have a much greater ability to shape the field of stimulation to the area that we want to affect as a result. We also have had a lot of advancement in battery technology over the last 20 years. We have a lot of different types today, and a lot of what we do with the education process is trying to figure out which type of pulse generator or battery is right for you. We have both rechargeable and non-rechargeable batteries. Rechargeables are great because they last typically for 10+ years, oftentimes 20 years before they have to be replaced, but you have to recharge them on a regular basis, and that might be once a week, up to maybe once every other day is probably the most you'd have to recharge it. We also have batteries that will run 2 electrodes, so if you have therapy on both sides of the brain, we can run both electrodes with 1 battery. And then there are different sizes and shapes to the different batteries from different manufacturers, and people may have preferences based on that as well. So this is really a conversation that you'll have with myself or with one of our mid-level providers to show you these devices and make sure you have the right one for you. The surgical procedure actually takes place in 2 parts. The first procedure is to place the electrode, and the second procedure is to place the battery or the pulse generator. When we place the electrode, it takes about 2 hours. You come into the operating room, we place a frame on the head, we then do our targeting with our navigational software, and then we create an entry point in the head so that we can place a electrode down through. Then we place the electrode into where we think is the correct target, and we actually turn it on and are able to determine whether or not we can arrest or reduce the tremor right there in the operating room. If we're happy with the results, then we lock everything into place. We tuck the other end of the electrode underneath the skin. We close everything up. Patient would stay in the hospital overnight and then typically go home the next morning. We then come back typically a week or 2 later for another surgery, which is under general anesthesia. It typically takes about 45 minutes, and you go home the same day, and that's when we place that extension lead down through the neck and then place the battery underneath the skin under the clavicle. This is just to show you some of the technology that we have available in the operating room. We get an MRI beforehand that we can look at in many different planes. We have a trajectory that we plan, and then when we place the electrode, we actually have an intraoperative scanner that we can then use to check the placement of the electrode and verify. You can see here these white dots are the actual electrode after it's been placed, and we can verify that it's right at the trajectory site that we wanted it to be. So we have a very high degree of confidence when the patient's leaving the operating room that the electrode is exactly where it needs to be. And this is probably the most critical factor in the success of this therapy, is making sure that the electrode is in the right place every time before you leave the operating room. After the whole system is in place, we typically want to wait a couple of weeks to let any swelling from the surgery to settle down, and that makes it less likely to have side effects when we turn it on. And then patients will come back and have it turned on either with Dr. Kamani or with the nurse practitioner. And then we go through a pretty exhaustive process to test every contact, every electrode, to make sure that we're getting the perfect set of stimulation parameters that will benefit you the most with the minimum number of side effects. So in terms of effectiveness, we know that there have been many studies looking at the effectiveness of essential tremor, and a couple of them are very good studies. A lot of them are okay, but we expect that we'll be able to reduce patients' tremors somewhere between 60 and 90%. This is what the American Academy of Neurology says. I think in our hands, we would expect people to get about an 80 to 95 or even 98% reduction in the tremor on the limb or arm that's opposite to where we're placing the electrode. We know that unilateral or single-sided stimulation means that 90% of our patients are going to be either moderately or markedly improved. So really good benefit, and it should last. There are studies now looking at 7 to 10 years out. There's a little bit of loss of effectiveness over time, but we think that may as much be due to the progression of this disorder as it is to any kind of loss of effectiveness of the device itself. We also know that stimulation of both sides of the brain can help reduce head tremor and voice tremor in most patients who have it implanted. And so just to know, patients can either have an electrode placed on one side or both sides, and it really is up to how bad the tremor is on each side that determines whether or not you get unilateral or bilateral treatment. In terms of risks, there are both two types of risks. There's risks of the surgery itself, and these are risks of pretty much any brain surgery. Some bleeding is a significant risk that we always talk about. It's about a 1% likelihood, very unlikely to happen, but it can have big consequences if it does. There can be temporary confusion, particularly if we're placing electrodes on both sides of the brain, and that's why we typically don't do that. At the same time these days, we will place the electrode on one side and then come back 3 months later to place the second side treatment to avoid any risk of confusion. Then obviously infection is another big risk that we're watching out for and take a lot of care in the operating room to make sure that we minimize that risk as much as possible. There are also then side effects of the stimulation. Just like a medication can have side effects, so can stimulation. If we turn it up too high, we're very likely to cause them, and we will then go through the adjustment process to get the best benefit, but also minimizing the likelihood of side effects. And these can be things like tingling, usually in the hands or the face, or it could produce some difficulty in enunciating words or some tongue thickening, and it can cause some muscle contraction. And then if we stimulate on both sides of the brain, we can affect balance as well as speech. And again, these can all be minimized or even eliminated just by turning down the stimulation. Here's an example of one of our patients who's doing what Dr. Kamani described was an Archimedes spiral, and you can see she's in the operating room before we place the electrode, and we're just kind of getting a baseline understanding of how bad the tremor is. And here is after we place the electrode. We haven't even finished the implantation yet, we just turned it on. And you can see that she is much more fluid in her movements, much faster. Really had a great result at a very low level of stimulation. And so this is the kind of thing we're looking for and trying to verify in the operating room before the patient leaves. And you can see here's a pre and a post implantation picture, and this is really what we're shooting for. So that's DBS. Let me talk about Gamma Knife next. This has also been around for quite a while. The technology's been around since the 80s, and it consists of a device that has 200 plus beams of radiation from what's called a cobalt radioactive source, and it emits gamma radiation. And those 200 beams all cross in one tiny space about 4 millimeters, or the size of a pea. And so what we do is we place a frame on the patient's head and then put the head into this device so that all those beams cross on that same nucleus that I've been talking about, that VIM nucleus in the thalamus. A lot of the targeting is done very similarly between Gamma Knife and deep brain stimulation and focus ultrasound. We first get an MRI, we look at where we want that radiation to go, and then we can actually block some of the beams if we think they're going to go through critical structures. But the goal is to basically create a lesion in the brain right where these abnormal cells are firing and causing the tremor. The benefits of Gamma Knife are that it doesn't need any kind of invasive brain surgery. It's a one-time treatment. It really only requires very minimal follow-up to make sure there's no side effects. It can be performed on patients who are undergoing anticoagulation, so people with atrial fibrillation don't have to be taken off of their medication to have this treatment. And most people will respond usually within 6 weeks after the therapy, but 80% should respond within 6 months. It's not something that kicks in right away, though. The risks of Gamma Knife: one is that it's a lesion, and so once we create that lesion, we can't take it back again. And if there are side effects, they tend to be very long-lasting or permanent. And those things can be things like weakness, paresthesias, which are tingling or numbness, and again in the hands or the face, or speech problems or balance problems as well. And typically we only treat one side of the brain with Gamma Knife to avoid any kind of cognitive side effects as well. In terms of the literature, it's a little more mixed with Gamma Knife than it is with deep brain stimulation or focused ultrasound. There is very good outcomes that have been reported. Here's a good paper showing that 81% of patients had a good or excellent response 2 years down the road. So that's a really good outcome. But that study was not done in a blinded fashion. And when they did a study back in 2010 in a blinded fashion with 14 patients, they found that there was actually no significant improvement in the tremor control at all that they could prove statistically, but they did show a moderate improvement in activities of daily living. So in that study, a little less convincing that it was super effective in reducing tremor. And so we do use this therapy, but it's employed, I would say, significantly less frequently than the other therapies. Last thing I want to talk about is focus ultrasound. It's kind of the new kid on the block. This technology is really impressive, and it's been FDA approved since 2016, but there's a lot less experience with it, and many fewer centers that have a significant experience with it. So what is it? It's MR guided focus ultrasound. It really consists of two pretty cool technologies. The first one is the ability to focus ultrasound beams, and it's similar to the Gamma Knife in that there's lots of different beams coming from different angles, but the difference is that there's over 1,000 beams of ultrasound, whereas there was about 200 beams in the Gamma Knife. And these are ultrasound, not radiation. So there's very little likelihood of causing harm in areas where the beams are passing through. But where all those beams cross, you can actually, in a very controlled fashion, increase the temperature of that target area. The other big development technologically is the ability to do something called MRI thermography. So when somebody's right in the MRI scanner, we can look at a map of their brain temperature and see, we want to create an increase in temperature in that tiny little area where we want to create our therapy, and make sure there's no other increase in temperature anywhere else. And we can do this in pretty much a real-time basis. So it provides us an ability to do very precise visualization and targeting before we actually deliver any kind of real therapy. So the advances are that it's very precise. We can do everything intraoperatively. We don't have to pass anything through the skull or the brain. in a physical sense other than these ultrasound beams. If there is no radiation involved, we don't have to do any sedation. We get good feedback. So we do this in the MRI suite, and we can test somebody while we're doing it to make sure we're getting a good response along the way. The therapy is done in sort of a cycle of what we call sonications. And so what we mean by that is that we do our targeting initially, then we turn on the ultrasound for typically between 10 to 20 seconds. We look at the temperature increase, we make sure it's in the right place at the right amount, and then we test the patient, usually with these same Archimedes spirals as well as other physical assessments. We check in to make sure there's no side effects, and then we go through that cycle again, and we keep going, applying more energy until we get to higher temperatures and get the result that we want. And in terms of the results, we have a very good study, which was really one of the best conducted studies in movement disorders, where the patients were blinded, the assessors were blinded, and there were a high number of patients, 54 patients that got the treatment in a blinded fashion. And you can see that the results show that there was significant improvement in the disabilities associated with essential tremor: eating, drinking, dressing, writing, working, all these things patients felt like were significantly improved. Same thing with quality of life, the ability to work, the ability to work on, money, financial accountability, hobbies, and sort of interactions with other people, the kind of ability to go out and eat at restaurants. All of this, patients felt there was a significant improvement. We now have 4-year data on the outcome from this pivotal trial that included these blinded patients. And we can see that after 1 year, there's a very good response in the hand tremor scores. And this is that same scoring system that Dr. Kamani was talking about earlier. This is not the amount of reduction of tremor in a percentage, it's a reduction in the score. Usually this is, again, somewhere between an 80 and 90% reduction in the tremor amplitude itself, but we can see that the outcome is very well sustained even at 4 years. We don't have very long-term data the way we do for DBS, but so far it's looking like a very durable therapy, both in terms of tremor reduction and disability. Here's actually one of the most recent patients that we've done in the Focus Ultrasound suite. This is the spirals before we started the therapy, and you can see the therapy started at 8:20 a.m. This is after each one of the sonications that we did. In the beginning, it's very low power. We're just doing the targeting, so we're not seeing much improvement. So you can see time is progressing from 8:20, 8:26, 8:30. We're starting to see a little bit of a reduction in the tremor. Here it's getting better. Better again by the 5th sonication that we've done here. We have a 6th sonication, and here right around 9 a.m. after the 7th sonication, we've had a very good improvement in the spirals and the ability to draw a straight line, and that was pretty much it. So you can see in 40 minutes we've gone from a very significant tremor to I would say a good 95% reduction in the tremor. And this is what we're looking for with this therapy with Focus Ultrasound. There are some potential side effects that can last for a long period of time. Numbness and tingling were seen most frequently in this study. 2 patients had a change in their taste that they described. About 8% of patients had some subjective or objective change in their balance. And then there was a handful of very unlikely side effects of either dizziness or some minor weakness or some difficulty in using the arm. And we did learn a lot in this study. We were participating as one of 11 centers. We can only do this therapy on one side of the brain right now, so we can only treat one side of the body. There are some characteristics of people's skulls that will affect how much energy we can get through to that target. So if somebody has a very thick or very kind of 3-dimensionally complicated skull, it can make it more difficult, and we get a CT scan in everybody, and it is possible that your configuration of your skull is just not right for this therapy. We also know that it can be long. It can take up to 3 hours in the MRI suite. So people that have a lot of claustrophobia or back pain, we have to be very careful that we're keeping people comfortable, and we need to discuss expectations beforehand so we're not caught in the middle of the therapy having somebody who's very upset at what's going on. So in conclusion, focused ultrasound thalamotomy is FDA approved for treatment of essential tremor in a unilateral fashion. It's very good in the fact that we can combine testing, the testing that we do with DBS, with the simplicity and one-time treatment of the Gamma Knife to produce a very good outcome for most people. But we do want to have longer follow-up so that we can kind of compare it to DBS in kind of a more comprehensive long-term fashion. So last thing I want to do is just show you, this is a patient that agreed to be filmed during one of the last patients of the trial that we were part of, and his name is Greg, and he let us film this video.
And I can hold
I'm going to turn up the sound here.
But it'll start back.
Marnie, if you can let me know if people can't hear
and then
this.
The doctors want you to do this, and this one just don't want to cooperate. But then bring your nose over here. I'll stick my finger on your nose and you see if I can poke you in the eye or not. Roughly about 20 years ago, I noticed that I shook a little bit. Not no problem. I mean, I could work. I did fine for a good while until the past couple of years. It's progressively gotten worse. It's completely affected my work. It's affected my play. It's affected when I go home. I don't want to work on things at the house because things just don't connect. You can't read my writing. We got paperwork that's got to be filled out. I can't do it. You know, I can't write a check, so my wife does all that. I don't go out and eat with people anymore. You know, putting food to your mouth and picking it up 3 times off the plate before it'll get there.
He went from being embarrassed by his tremors to more frustrated. The more frustrated he gets, the worse his tremors gets. So it's a vicious cycle. It's been hard.
So I was just at a point that this is, you know, there's nothing gonna happen unless they come up with something. And I never would have thought in my lifetime that they would have come up with a focused ultrasound.
Focused ultrasound is a brand new therapy where we can combine MRI technology to image what's happening inside the brain with a focused ultrasound to be able to basically raise the temperature in very small parts of the brain to deliver therapies. It's really exciting for me because, you know, as a neurosurgeon, we're used to opening the head and going into the brain and providing our treatment. And it can be very effective, but it's very, very invasive. This technology is you know, kind of miraculous because we can treat lesions or problems that are inside the brain without ever going into the brain physically.
This is a game changer, I hope. I've got all the hopes in the world. I've got plenty of people on my side.
For almost all of my patients, this is a huge kind of fork in the road for their future. And I never lose sight of that fact. People can be very transformed from having significant disabilities and really tough daily life to having a really great quality of life in a matter of hours.
I don't know why I'm nervous. I'm just ready to see him, you know.
Yeah. So let me go back and look at it again. Might be finished here.
Did it work?
now we're opening up a whole new world of potential new therapies for patients who have chronic neurologic conditions. So spasticity with multiple sclerosis, Parkinson's disease, patients who have epilepsy. So this is just a really exciting time to realize that we have a tool that is, minimally invasive, and now we know it's very effective for at least one condition. And now we can start applying it and seeing how it works with other conditions. We're on the brink of a whole new frontier of treating neurological problems.
You want to tell them?
Hey, it worked. It worked. Yep. I love you. Bye.
Touch my nose like you did before.
Boy, poke your eye out.
All right, I think I'll go ahead and take these slides down. I want to thank everybody for paying attention for such a long period of time. I know it's tough sitting in front of a computer for so long, but thank you guys. I will, I think, turn control back over to Marnie.
Okay, thank you everyone for attending. We are going to move into the next session. Please let me know if I have an echo. So, Dr. Kamani, thank you for going through and answering some of these.
Marnie, I hate to interrupt you, but there is a little bit of an echo. I'm not sure if the audience is feeling an echo as well. I can hear it a little bit.
Little bit. I think it's still okay, but it is small.
Okay, I will try and back away from my computer a little bit as we go through these. So, first question is, I don't qualify for focused ultrasound and I'm not interested in having DBS. What is the success rate of Gamma Knife? Dr. Gwynn, I believe you did answer that question in some of your slides. So if the person that asked this question wants further follow-up, please email swedishneuroeducation@swedish.org. I have published that email address in this comment section. We'll move on since we're short on time.
Sure.
Dr. Gwynn, I have essential tremor. I also had surgeries for brain aneurysms resulting in 5 plates and 21 screws. Can I still do this procedure?
Oh, that's a good question. I would say that really depends on whether or not you can have an MRI scan. If you can have an MRI, that makes you potentially a candidate for both the focused ultrasound and the DBS. There are more limitations for focused ultrasound. But it really depends on where these plates are, what kind of metal there is implanted, and whether there's kind of injury to parts of the brain in the pathways that we want to interact with. So I would say that it is possible, but I can't promise it without really getting a good comprehensive understanding of that patient's individual circumstance.
Thank you.
Mm-hmm.
Dr. Kamani, for some of these questions, you answered several of them. Do you want to run through some of your answers, or should we skip ahead?
I think in the interest of time, we should skip ahead. I hear echo again. I apologize. To Dr. Gwynn's questions, there were several questions on the surgical treatments of essential tremor that I sort of saved for Dr. Gwynn. We need to focus on those so that those could be answered. I answered as many medical questions, and I'll continue to type some answers while Dr. Gwynn answers some of those surgical questions, if that's okay with Dr. Gwynn.
Oh, sure. Yeah, that sounds great.
I am skipping ahead trying to find some of those questions.
Yeah, there are a lot of great questions out there, and I'm sorry we can't get to all of them. This is the kind of thing that would be nice to be in person and kind of, come up and talk afterwards. But a lot of good questions.
So what is the success rate of focused ultrasound?
Good question. As the slide indicated, I would say that it is very, very similar to DBS. We expect to get an 80 to 95% reduction in the tremor. There is a more than 47% reduction in the tremor scores, which again is very comparable to deep brain stimulation. And there's a little bit of falling off effect in the first 2 years, but then still a very, very durable effect that goes out for 4 years. So we expect, more than 90% of our patients to have a better than 80% reduction in their tremor for at least a few years.
Thank you. Sifting through the questions here. Can focused ultrasound be used for a person with cervical dystonia?
Oh, good question. We are not treating cervical dystonia or any kind of dystonia with focused ultrasound yet. We are actually in the middle or the end of a study to look at treating Parkinson's disease using a different target called the globus pallidus, and that target is the same target that we often use to treat dystonia with deep brain stimulation. So a long-winded answer, but there's a chance that in the future we will be able to treat this with focused ultrasound, but as of now, no.
Thank you. Another question, since I already have DBS on one side, it's been said that I would not benefit from having it added on the second side. It would definitely affect my speech and balance. My speech is already slurred. I'm on permit down 100 milligrams and Mazapan twice a day. Neither one is helping.
We could probably both answer that, but I would say that, we very frequently treat both sides of the brain. And I would say that if somebody has a lot of speech problems with just one side implanted or balance problems, that does make us a little bit more kind of wanting to be very thorough in our assessments. But I would say that, we'd want to see the patient and make sure that the programming has been done properly, make sure that the first electrode was in the right spot. And if we feel like it would be safe and effective, we would definitely put it in the other side as well. But again, I don't want to promise anything without really being able to do a good assessment on that. What do you think, Dr. Kamani? Oh,
Let me unmute myself. I think I did answer the question. Is this about focused ultrasound and cervical dystonia?
Oh, no, this one's about treating the second side with DBS if somebody's already got balance problems from the first side or speech problems.
Right. It's a complex question. There is no guarantee that the balance or speech is going to get worse just by surgical implantation. In my experience, it's the programming as well, turning the electrode on, that can cause speech and balance problems. In the era of multiple independent current control, current steering, those side effects can be significantly minimized. So it is the answer is a little long-winded. It would depend upon the amount of functional limitation the tremor on the opposite side is causing. If it is the dominant side that needs to be treated, I would explore DBS for the opposite side, and and the programming needs to be done carefully with a newer platform that has these functionalities that you explained, Dr. Gwynn, to reduce the potential side effects. It would have to be a good communication between ourselves and the patient, but there is no given, there is no guarantee that just by operating on the second side, your balance and speech problems are going to get worse.
Perfect, thank you. Next question, for focused ultrasound treatment, can the patient take something like Xanax to help with the claustrophobia of being in the MRI for up to 3 hours?
Oh, sorry, I was typing. Can you repeat that one more time for me?
Yes. For focused ultrasound treatment, can the patient take something like Xanax to help with the claustrophobia of being in the MRI for up to 3 hours?
Yeah, that's a good question. And typically the answer is no, unfortunately. The problem is that we really want the tremor to be there during the testing. And if we give a lot of medication to make people more comfortable, we also tend to take away their tremor at the same time. And then we lose our ability to know kind of when we're finished with the treatment. And so I would not say that we have never ever done it under any circumstance, but if somebody has a lot of claustrophobia, that is kind of a sign that maybe this is not the right treatment modality for the patient. But you know, typically we get an MRI. We always get an MRI beforehand for kind of targeting purposes, and I often use that as kind of our test circumstance to know whether somebody's going to be able to make it through the actual procedure itself. But people do have to have some ability to limit that claustrophobia.
Thank you. What is the follow-up for focused ultrasound? Do you follow up with the patients?
Yeah, typically we do this in the setting of, again, a team condition, and patients have a movement disorder neurologist, and we'll often be following up with the movement disorder neurologist on a regular basis, and the assessments are done that way. We typically also follow up about 3 months after with the surgical team to make sure that everything's gone well and that there are no side effects. Dr. Kamani, any other thoughts on that?
Yeah, I think I answered that question. In our practice, with focused ultrasound after the procedure, your team sees them in a month, I see them in a month on the same day, then I follow them every 6 months and a year to collect data, because I don't think we talked about this, but briefly, we are collecting outcome data on everyone who's had surgical treatment for tremor. So it's important that you come back and let us evaluate you to determine if there is durability and sustained improvement. So, you know, we can improve our own program and get as much information as possible. So yes, there is regular follow-up for focused ultrasound. If you're able to come back and visit with us, it would be great.
Next question, can you be on Eliquis with FUS surgery? That's focused ultrasound surgery.
We have treated people who require Eliquis in their lives, but we cannot do the therapy while they're on the medication. So people would have to be able to bridge off of their anticoagulation like Eliquis for a period of time, typically about 2 to 3 weeks off of that anticoagulation so that we can do the therapy. Then they can be safely put back on again afterwards.
Someone questioned bilateral focused ultrasound.
Oh, that's a really good question too. That's something we're very interested in. We have not done that here. It is not FDA approved to do that, but it is being studied. And I know that there's a study taking place in England right now where they've treated a number of patients in a bilateral fashion, but I do not have the outcomes of that study yet, and I cannot kind of promote that as of now, but it is definitely an area of intense interest and research.
Dr. Kamani did answer this question, but I think that others might have the same question. Does Medicare or health insurance help to cover these procedures?
The answer is yes. It is covered by Medicare. Focused ultrasound is covered by Medicare in all states as of a couple months ago. It has taken a long time to get Medicare coverage. Deep brain stimulation has had Medicare coverage and every other insurance coverage for many, many years. So in today's world, we should not have problems getting either of these procedures approved.
Excellent. Well, I think we've made it through all the questions that Dr. Kamani did not answer.
Sorry, Marnie, there was one that Dr. Gwynn may have answered, but I might have missed it. Dr. Gwynn, there was a question on, can you have DBS after FUS? Did you already address that question?
Oh, not yet, no.
Okay.
And so that's a good question as well. And the part of the question is whether you're talking about treating the same side or the other side. So in the circumstance where you've done focused ultrasound and for whatever reason it didn't work, you can come back and do DBS on that same side if there is still a target there. And so what I mean by that is that if we created a very good lesion and a patient had a very good response, but then it wore off over a period of time, I would be a little bit more nervous about treating the same side again, because we might not have a good target left to treat. And I have not yet done that in this circumstance, although I am thinking about it. Luckily, there just aren't a lot of people that have kind of got that much worse afterward. In terms of the other side, yes, very easily, and we have done this a number of times. We've done focused ultrasound on the first side and then gone back and done deep brain stimulation on the other side. Because after people realize the benefit of focused ultrasound, unfortunately we can't do it on both sides, so they start to realize that, yeah, having some sort of treatment is really, really helpful, and then they were initially not wanting to do DBS and then eventually are okay with it on the other side because they realize how much their lives are improved with these treatments.
And I've got one more question. As a person that does not prefer pharmaceuticals as a primary method of treatment, would that eliminate me for any possible consideration for focused ultrasound?
Dr. Kamani, do you want to take that one on?
Well, if we do things by the book, which we like to do at Swedish, and most people should, focused ultrasound and both deep brain stimulation are reserved for medication refractory tremor. It is entirely possible that your own insurance company may not approve the procedure if they found out that you haven't tried 1 or 2 medications for essential tremor and failed them or not tolerated. So my short answer would be you must try the medications and try them honestly. That is really important because ultimately it is a brain procedure, and currently it is reserved for those people who have tried and failed the medications that we typically give people. And if you really don't want medications, there is still Calatrio, for which you don't have to have a prerequisite to to take pills. So I'm going to see if Dr. Gwynn has a different take on doing any of these procedures on completely drug-naive patients.
Yeah, no, I wanted Dr. Kamani to answer first because people really have to be assessed and approved by the movement disorder neurologist before I want them to even get to me. But I would say that, it really depends on what has been tried. If somebody has tried propranolol and primidone but couldn't tolerate them because of the side effects, and that's the reason they went off of those medications again, I would consider DBS or focused ultrasound in that setting. But I agree with Dr. Kamani that we really want people to have at least tried these medications, because if you can solve your problem with a medication that you can tolerate, that is much better than undergoing any kind of brain intervention that has significant risks associated with it.
With that, I think we'll thank everyone who attended. I know we slowly have people drop off, probably getting back to their regularly scheduled programming. If you have follow-up questions for us or would like more information, please don't hesitate to reach out. The email address is on the screen. It's swedishneuroeducation@swedish.org. We will have a recording available of this event, so we are more than happy to send it to you, but you'll need to email us a request first.
Great. Thank everybody so much for coming and paying attention. We really appreciate it.
Thank you, Dr. Gwynn. Thank you, Marnie. Marnie, once we end the session, will the unpublished questions go away because there are about 40 unpublished questions?
No, we will be able to see those, and we can send follow-up to anyone who has emailed us.
Okay, great. Thank you, Dr. Gwynn.
Thank you.
Everybody have a great weekend.
Thank you, Marnie.
Thank you, Marnie.
Thank you.